Okay, good evening, everyone, and good morning for those who are joining us from the United States, or good afternoon for those who are joining us from elsewhere in the world. So good morning, good afternoon, and good evening from wherever you are joining us. Thank you for registering for this interesting webinar about the hot trending topic, COVID-19. And we would like to, first, I would like to thank the University of California, San Diego Health Sciences for accepting this invitation by the Saudi Pharmaceutical Society. And we would also like to thank the Virtual Medical Academy for offering this meeting for free for everyone who signed up for it. So this was basically a joint collaboration between the Saudi Pharmaceutical Society, the University of California, San Diego Health Sciences, as well as the Virtual Medical Academy. Tonight, we're going to have a few presentations. The main presentation will be provided by Dr. Jisan on the treatment of COVID-19. And then we would also have a few words from the some of the faculty at the University of California, San Diego Health Sciences. So first, we're going to start with Mrs. Maureen Quran. She's going to give us some welcoming and introduction. Mrs. Maureen is the Director, Administration and International Business Development for the University of California, San Diego Health Sciences International. She is responsible for creating, maintaining, and enhancing the University of California, San Diego Health Sciences International services by fostering worldwide partner relationships. So with that, we would like to welcome Mrs. Quran, and she can start her introduction. Mrs. Quran, are you with us on the webinar? Probably we can wait one more minute for her to join in. Okay, we had about 2,700 people who signed up for this program, and right now I believe we have more than 700 attendees joining in, and we're expecting that the number goes up in the next few minutes. I think if Ms. Quran is not available, we can go to the next section of the agenda. So until Ms. Quran comes back, and then if she has anything to add, then we can welcome her back. Okay, so our next speaker is Dr. Mounir Soliman. Dr. Mounir Soliman is an Assistant Vice Chancellor and Executive Director for the University of California, San Diego Health Sciences International. Dr. Soliman provides the overall leadership and strategic direction for the development of programs for Health Sciences International. He works closely with the senior leadership to align the international service lines with the UC San Diego Health's core mission. He is instrumental in advocating and promoting leading-edge research, advanced education, and innovative clinical programs. Dr. Soliman is also a clinical professor of psychiatry. So Dr. Soliman, if you are joining us on the webinar, we would like to welcome you, and you can start. Dr. Soliman, are you online? It looks like we're also missing Dr. Soliman from the call. Okay, Dr.
Doctor, you
Dr.
can
Mounir
click
Soliman
on
is
the
with us.
mic, please. Click on the mic in the above of the page.
On top, there is a small mic icon on the top left of the screen. You can click on it.
Can you hear me now?
Yes, we can hear you now. You can go ahead, Dr. Soliman. The stage is yours.
All right. All right. Well, thank you all so much for my team and also all of the wonderful people in Saudi Arabia who have arranged for this. And the special thanks to my colleague, Dr. Sun and Dr. Delaney, who made themselves available during this critical time of the healthcare emergency that we have. I want to share with you a few things that University of California, San Diego became at the forefront with the outbreak of coronavirus probably a few months ago. We were the first hospital in the nation to receive cases from China, and we had treated the first 2 cases actually at UC San Diego. And then, as we all noticing that the outbreak is going so fast and is overwhelming our healthcare system, and we find ourselves not only leading but also forging this kind of relationship worldwide, because we cannot fight this alone. And I am so appreciative for the opportunity to share our knowledge and also our science today with many people all over the world, and our hope that we will pass through this and we will all gonna be successful in fighting this. But what's important at this point, despite all of the challenges that we are facing, that this event is bringing us closer to each other as a human being. And I think the value for spreading quality healthcare and being collaborative, first of all, this is what would make our effort successful and be able to move forward beyond the coronavirus. So I want to let you know that we're here at UC San Diego. We are like the capital of research and the science, probably in the region. University of California, San Diego is part of about 11 campuses within the University of California, which you consider the largest healthcare system in the whole entire world. And we have an open door kind of policy for sharing knowledge and skills, and also extending our hand to our partners worldwide to move forward with capacity building. So with that said, I want to emphasize the fact that we're here for each other. We're not here only for ourselves, but we're here for each other as a human being, and we're here to do whatever we can to assist basically with the foundation of science and extend our collaborative approach to make sure that we are doing this the right way and we're following the guidelines that it is set by many governments, and all of them are similar. So I will stop here, and then I will give the microphone probably to Dr. Delaney, who is the head of our education and the training program at UC San Diego Health Science International. Pat?
Dr. Delaney, we can't actually hear you. Okay. So just if you can just let me introduce you very briefly. Our next speaker is Dr. Patrick Delaney. Dr. Patrick is a clinical professor of neurosciences at the University of California, San Diego. He also serves as the Director of Education for UC San Diego Health Sciences International, where he oversees the education and training of international physicians, pharmacists, and allied health providers. So the mic is yours, Dr. Patrick.
Thank you. UC San Diego Health Sciences International is pleased to be a host for today's seminar. Obviously, never has there been a greater need for global exchange of pharmacological and medical information than right this minute. For the past 10 years, Health Sciences International has been coordinating the global exchange of information and technology for UC San Diego as you just heard from Dr. Soliman, UC San Diego is a recognized world leader in the biomedical sciences. I think at the moment, the institution's ranked 5th globally in pharmacology and toxicology and 6th in microbiology, for instance. With that backdrop, though, I'm especially pleased to introduce Dr. Ji Sun, who is the manager of the Investigational Drug Service for the UC San Diego Health System. He's an assistant clinical professor at the Skaggs School of Pharmaceutical Sciences here on campus, and he attained his pharmacy degree as well as a master's at Peking Union Medical College and the Chinese Academy of Medical Sciences. Dr. Sun went on to accomplish a Ph.D. in pharmacological and molecular sciences at Johns Hopkins University. He's a board-certified pharmacist who is active clinically in our chemotherapy infusion centers and is a research pharmacist who, again, manages the investigational drug service here for the entire health system. Dr. Sun will be speaking today about COVID-19 and aspects of experimental therapy, as well as the role of pharmacists in the pandemic. So please join me in welcoming Dr. Sun.
Dr. Sun, we are pleased to have you here on board, and we really sincerely appreciate you accepting this this opportunity for joining us. If you just let me briefly introduce you as our main speaker tonight. So Dr. Ji Sun is the director of the UC San Diego Health Investigational Drug Service, as well as a clinical pharmacist and clinical assistant professor of pharmacy. The research the pharmacy makes UC San Diego's clinical research operations more efficient, effective, and comprehensive, as well as allowing for investigational drug compounding. We welcome you, Dr. Sun, and the stage is yours.
Can you hear me?
Yes, we can hear you, yes.
You can? Please let me know if you can hear me, if the volume is right. Okay. So good morning and good evening. You can. Okay, great. Good morning, everyone, and I know we are on a different time zone. Thank you for the introductions, and I really appreciate this opportunity, and so that I can share our experience to treat one of the first COVID-19 patients in the United States. I'm going to provide some insight and experience as a frontline research pharmacist or clinical pharmacist, and our role in this global pandemic. Whenever we have a new disease and when people have no experience and no therapies, when we encounter a new disease, this is really a challenge to the entire humanity. So, but even though we're in a global pandemic, there's always a hope, and so that is the major tone of my talk. Is there are cures and therapeutics out there being tested, and even though the situation is very dynamic right now, but I'd like you, the future and then the current healthcare providers, to continue to look for science and continue to look for better therapy. We were put on the spotlight early this year, and really this coronavirus, the COVID-19, is an illness caused by a novel coronavirus, and now it's called SARS-CoV-2, as opposed to SARS-CoV-1, which circulated back in 2003. So the outbreak of the illness happened in Wuhan City, Hubei province, at the end of 2019. And it was initially reported to the WHO on January the 1st, 2020. And in about a month, it became a national outbreak. And on January the 30th, WHO declared COVID-19 as a outbreak, a global health emergency. And on March the 11th of 2020, the WHO declared the COVID-19 as a global pandemic. And it's the first designation since the H1N1 influenza pandemic in 2009. So let me move on to, I have nothing to disclose. I have no conflict of interest. And the information in my webinar is from the public domains, including the clinicaltrials.gov, because most of the drugs I'm going to discuss today are all under a clinical trial or are being used as an off-label. And you can also, I extracted a lot of information from the PubMed. So there are three objectives I'd like to achieve today. The first objective, I'd like to provide an overview of the recent updates in the treatment and the management of the COVID-19. And second objective, I'd like to discuss the, and using our case as an example, I'd like to discuss the potential of using the Remdesivir as a usable agent for the COVID-19 therapy. And the last, during this, the majority of the time will be spent on number 2, which is to, not only the Remdesivir, I'm going to talk about chloroquine, hydroxychloroquine in combination with azithromycin and other vaccine trials. And the last objective is a pharmacist to pharmacist talk is the lessons we learned and what I think is the future, the direction of the research and the medical care. Hopefully we can help you to acquire some skills as a pharmacist in the management of this new disease. So before I start on the discussion on the first objective, I'd like to introduce you to the Investigational Drug Service at UC San Diego. And overall in the United States, any hospital participate in the clinical research would have a division of the clinical pharmacy department, which is I'm the director of this division. And each IDS or Investigational Drug Service pharmacists support between 40 to 50 clinical trials. And at any time of the year, we support up to 500 clinical trials at UC San Diego. University of California is is always at the forefront of the scientific research and the medical research. So we have a 5 medical campus, and each medical campus support about 500 clinical trials. So that's our routine work is to support the majority of our clinical trials have been focused on the oncology, mainly done at the Morris Cancer Center. And we have other clinical trials for different indications. So our daily job is to provide a research pharmacy service to the major hospitals' inpatient trials, and also we provide pharmacy service to outpatient clinical trials. So I highlighted here we also provide a research pharmacy service to emergency use of investigational new drug. Abbreviation is called eIND, which is the case for the COVID-19 patients. So that's why we are doing unique things, which is whenever there is no standard of care, and whenever a FDA not approved medication is used to treat disease, and it will go through our service. And we have a very established infrastructure to process clinical trials and in a short period of time. So the disease. So I'd like to start a little bit to talk about the disease, the pathogen, and a little bit of epidemiology of the disease, and virology of the disease, biology of the disease. So we have a good understanding of what we're dealing with, and how the new virus make us sick, and what are the strategies and to develop therapeutics. So this is a schematic picture of the COVID-19, and as you can see, the under the electron microscope, they are named these crown-shaped surface spike proteins give them the name of a coronavirus. And the epidemiology of this new virus, it was identified on December the 27th. 3 cases of clustered cases were reported in Wuhan, China, and on January the 3rd, the WHO was notified. And January the 7th, it was the first time that the SARS-CoV-2 was identified. In about 3 days, the sequence has been shared with WHO. And as many of you know, that the RT-PCR has been the main diagnostic tool to, as the testing kit. And RT-PCR has been developed pretty much as soon as the sequence was shared, and it was sent to Wuhan for clinical diagnosis. So the outbreak really happened between the 11th and the 23rd. And during that time, it was known that the disease can be transferred between human. And so that's why the Chinese government exercised the city's shutdown. And from the 23rd to the 31st of January, Wuhan and then the neighboring 15 cities were shut down. So in about a month, this quickly spread to all over the country. And that's why on January the 30th, WHO declared a global health emergency. And at that time, the U.S. government decided to withdraw the citizens from Wuhan city, and Department of Defense evacuated the citizens from the Wuhan city. And San Diego, one of the local San Diego military base, received about 230 evacuees and who were quarantined. And our hospital received the patients who were confirmed to have a COVID-19. And one of the patients received the therapy, and we provided direct patient care. That's the case I'm going to share with you. So locally, the situation was relatively calm, and but several countries started to see patients, and then the outbreak happened in many countries. So, and I'm sure you have seen this in the news, that I will show you a snapshot of the global pandemic. And on March the 11th, WHO declared a pandemic. And so we, as a city, received another about 490 passengers between March 10th to the 20th. So I call it a calm before the storm. And it's really, now we have over 490 passengers from a cruise ship, and which docked in Oakland. And San Diego received 490 passengers. And we're doing, because we were, our hospital have the experience to deal with so many COVID-19 patients. So that's why we receive another 490 passengers. So this became a pandemic, and I think all the local government and federal government are taking measures. For example, our governor declared the shelter in place so that effective on March the 19th and then the 20th. So most of the people, non-essential personnel are working from home for at least 2 weeks, which can be extended anytime. So I run this, this is a good website to track the global pandemic, and I ran this yesterday afternoon, but this number has increasing on a daily basis, and over 329,000 globally has been infected. So I ran the, yesterday there were 511 cases in Saudi Arabia, but this morning I believe there is another clustered cases reported. If this website can be shared with you, and so that you know if how many cases are in your country. So it's a very challenging time globally. So we have to work together to find a cure here. So coronavirus. So the step one is to we have to have a good understanding of what it is. And coronavirus family has been with the human for hundreds of years. So there are 3 or 4 common coronavirus species, including the NL63, which circulated in human for about 500, 800 years. And 229E has been with the human for 200 to 300 years. And OC43 has been with humans for 120 years. These are the benign coronavirus species, meaning that they have a low pathogenicity. So these viruses actually only cause mild symptoms, for example, common cold, and then the infected sites are the eyes and noses. In the past 15 to 20 years, 3 species started to circulate in human with high pathogenicities. So including SARS-CoV circulated in 2003, caused 8,000 exposures, not exposure cases, and 773 people died from SARS-CoV-1. And in 2013, MERS circulated in Saudi Arabia, and the third is the new COVID-19. So I put a SARS-CoV-2 here so that you know that this new coronavirus is very similar to the original SARS-1, even though the official name is COVID-19. So next, biology of the COVID-19. This is a RNA virus with a relatively large genome of 32 kb, and both the genome and as I just show you the genome is packaged inside of this the core of the virus, and on the surface of the virus are these spike glycoproteins. Both the genome and the glycoprotein have a very high mutation rate, which makes it very challenging to develop vaccines and therapeutics. So the RNA, there is a high rate of RNA recombination, including the mixed infection. After multiple rounds of infections, the RNA will mutate. There could be a large chunk of genetic modular evolution, meaning that a large chunk of RNA can be swapped. That's how the genome mutate. At the same time, the surface glycoprotein also experience mutations, including deletions, insertions, and recombinations. So how does it infect the human? Similar to SARS-1, the binding site has been identified to be the human ACE receptor 2, which is highly expressed in the human's epithelial cells in the lung. That's why it caused the pneumonia, similar to SARS. And ACE receptor, as many of you know, that it's the play an important function in the blood pressure control. And we'll discuss how ACE inhibitors for hypertension. What is the how do we look at the relationship between ACE inhibitor and the potentially increase the risk of infection. So this is a paper published in Science in March, which shows this is a X-ray crystallography of the spike glycoprotein of COVID-19. And as you can see, this is a trimer, and it gives the crown shape of the virus. The receptor binding domain is shown here in this green box. So this is how the virus, what it used to attach to the human ACE2 receptor. And the binding of to the ACE is comparing to the SARS-1, it is 10 times more tightly than the SARS-1. And the reason it is important to understand how the virus attach and enter the cells is because this will be the region that potential therapeutics can be developed, and potential diagnostic tools can be developed to detect the virus. And imagine that if we develop a monoclonal antibody that can block this interaction between the binding of this region to the human receptor. So, so the clinical course of the disease. So lots of these are extracted from the report from the Chinese CDC, Dr. Wu. And most of the patients, the top 3 symptoms include fever. 80% of patients presented with fever. This is not high fever, and it's a feverish or a little warm. And the second is a dry cough. 50% of the patient would have a dry cough. Fatigue, 40% of the patient will have a fatigue. Most of these patients would have chest CT findings. And incubation, once exposed, it takes about 5 to 6 days for patients to have symptoms. And though the range can be 2 to 14 days. And at the clinical presentation, at the diagnosis, majority of the patients are 80% are in the mild and the moderate category, and 15% of the patients presented as a severe disease, and 5% of the critical patients presented as a critical. Fatality rate, the average fatality rate is between 3.5 to 3.7, and it increases with age, and especially for senior people in the 70s and 80s, the fatality can be as high as 16%. Once exposed, and it's especially worse in senior citizens, and twice as many men die from the disease than female. This is a little interesting because the receptor-wise, as I mentioned, the ACE receptor is actually expressed higher in a female than male. So that's still we still don't know why men die from the disease. More men die from the disease than women. Underlying disease and for patients with underlying disease, actually the death rate is higher. So the underlying disease has been identified to be hypertension. I highlighted red is because of the reason of the ACE receptor expression. And is there any connections? We don't know. Diabetes patients with lung disease and cardiovascular disease, those are the patients are more vulnerable to COVID-19. So most of the death are from ARDS or acute respiratory distress syndrome. So viral shedding, this is very important. Comparing to SARS, the viral shedding, it happened as early as 24 to 48 hours before any symptoms. So, as opposed to the SARS, the peak of the viral shedding is 5 days after the symptoms. So it was easier to control SARS because when people have a symptom, you isolate them and virus shedding will be more and more. So at that time that you know that who is sick and you should distance yourself from those patients. But the COVID-19, unfortunately, the viral shedding already started, and actually the peak is before people know that they are already contagious. So this is critical for the early diagnosis and rapid testing, large population surveillance. So clinically, when people worsen clinically, and interestingly, the virus titers start to fall, and suggesting that at the later stage of the disease, it's the patient's own immune system, or there is a inflammatory pathogenesis. So the reason I want to point this out is when we are discussing the treatment and management, and antiviral drug may not be a good time to start later of the stage, because the viral titer was already low at the later stage, and then the focus of the treatment should be on the inflammatory pathogenesis. So let me move on to discuss our first objective, which is the overview of the recent updates in the treatment and management of COVID-19. So this is as of today, there is no FDA-approved therapeutics or drugs or vaccines to treat, cure, or prevent COVID-19. So if I quote from the director of National Institute of Allergy and Infectious Disease, Dr. Fauci, there is no magic drug for coronavirus. So before I dive into pharmacological management, I have to discuss the non-pharmacological management, especially in this pandemic, in the absence of FDA-approved drugs. So these are very important besides looking for drug therapies. So epidemiology interventions are critical, including the early detection and isolation. As I mentioned, that this disease is very contagious, and it can spread in the community before people know. And early detection will help to identify the personnel infected and so that they can be quarantined or isolated. In the hospital settings, as healthcare providers, we should exercise contact, droplet, and even airborne precautions. So even though the guideline has been changing all the time, should we take the aerosol precaution, or should we take the airborne precautions? And the guidelines are changing. And one necessary limitation of the travel to and from the areas affected is very important. And locally, city-wise, state-wise, we are exercising social distancing, and if necessary, actually, at San Diego, all the schools, middle school, high school, and elementary school, and universities were closed for at least 2 weeks, and can be much longer than that. And if necessary, the entire state can be locked down, and that's what happened in California, that our governor declared shelter in place on March the 20th. So these are epidemiology interventions that can help to slow down the spread of the viruses. Once you have a patient quarantined and thus admitted to the hospital, and right now, remember, 80% of the mild and moderate patients can recover on their own. And in the absence of drugs, the supportive care is the standard of care. So meaning that if necessary, you need to supplement oxygen and use the provide mechanical ventilation support. So when we do not have any, when we practice on the front line, and as a research pharmacist, even though we are used to having no guidelines, because we are the ones who collect the data, and to look for, to write guidelines for new therapies, and majority of the pharmacists, the community, would have something to follow. That will be the FDA-approved drugs, and with established dosing guidelines. But this is a very unique situation that you open the textbook, there is no drugs, and you go to clinical pharmacology online, there is no drugs for this. And everything is by extrapolation from the treatment of other similar viruses, and also the some of the drugs are being investigated because of the in vitro and in vivo data from the animal model, from the cell culture. So everything we're using today are under clinical trials. So before we discuss specific trials, specific therapeutics, I'd like to, I think it's critical for me to explain what the difference between a randomized controlled clinical trial versus a expanded access trial, because you will have a large body of clinical data reported in the literature in the next few weeks, if not months. And you will see many trials launched try to find a cure or therapeutics. And how you read the data. So randomized controlled trials are textbook clinical trials, and they are designed to test the safety in the phase 1 and efficacy in phase 2 and 3. So randomized controlled trials take many years to complete, and most of the time you have a active drug compared with a placebo. They are lengthy, but it's vigorously designed, and robust data can be collected from hundreds, if not thousands of patients. This is primarily the trials used by the FDA to approve medications, new medications for disease. And expanded access, so it's a emergency use if appropriate, meaning that the under life and death situation, it's okay to use a drug that is not FDA approved, or if you have no access to the drugs that is being tested in other centers. So FDA do provide a mechanism that would allow the physicians to use a drug and to save lives. The data can also be collected and used for the FDA for eventually the approval of the drug. So in our case, we use this pathway, which is the expanded access, because back in February there is no this Remdesivir has been used in other clinical trials, not for this indication, and so that's why we and our patient was not doing good. So that's why we have to urgently treat our patient with a study medication. It was fast from the time we decided to treat to the first dose was given. It was only in a few hours. And expanded access are always open labeled, so the doctors and patient know what they're using. The treatment and management. Treatment can be loosely classified into antiviral agents in this slide. And the second class would be the vaccines for prevention. And there is a third class of treatment, is the later stage. At the later stage of the disease is the anti-inflammatory medications. So I'm going to start with the antiviral agents. And there are a few investigational agents, including Remdesivir, that we used to cure our patient and manufactured by Gilead Sciences. And as many of you have probably already read the literature about the chloroquine and the use of hydroxychloroquine in combination with azithromycin. And there is in the second objective, I'm going to have a more discussion on the trials for this combination. The next is the HIV protease inhibitor, Collateral. This is a failed trial, and which was published in New England Journal of Medicine probably last week. And antiviral agents also include immunoglobulin and monoclonal antibodies against the COVID-19. As I mentioned earlier, that you may develop antibodies which can block the entry of the virus to human epithelial cells. And also, there are patients who already recovered from the COVID-19. Immunoglobulin can be purified from their serum, and which can be used for other patients. So the second type of treatment is the anti-inflammatory agents. As I mentioned, in the later stage of the disease, and especially the ARDS, and most of the patients' immune system the virus triggered a cytokine release storm, or cytokine release syndrome, or cytokine storm. So, this is our own immune system react too violently that it already caused our own damage. So that's why multiple drugs historically used to suppress immune system, including the corticosteroid, and have been tested with the conflicting results. Interleukin-6 has been shown to have increased expression. That's why anti-IL-6 modalities have been investigated and could be investigated. JAK inhibitor is another immune modulator that is potentially be used. So vaccines. So this can take, this is a disease that eventually, hopefully, the entire humanity can develop some kind of, it's so new that none of us have a defense against. So one of the important category of treatment is not a treatment, but a prevention is the vaccines. So there are multiple platforms of vaccines developed. including the genetic immunization using the RNA and DNA. And another platform is the use the viral vector adenoviruses. And recombinant proteins can be used as vaccines. Nanoparticle, which the viral protein is absorbed to the particles, can be used as vaccines. So vaccine trials will take some time to, even though NIH already started a vaccine trial, and the first patient was injected in Seattle. But for vaccines to develop, vaccines historically had complications. And especially for this COVID-19, the efficacy can be compromised or in the aged populations, and who actually need the vaccines more than other age group. And because they just simply fail to launch a robust immune response to the vaccines. And then the other unique thing for this group of the coronavirus group 2B is the rapid, they're very heterogeneous, and as they can vary as much as 35%, meaning that if you use one strain of COVID-19 or coronavirus to develop a vaccine, it may not cross-react with other strains because they quickly mutate. But the vaccines will take some time between some report shows that it will take about 18 months to have a successful vaccines, and then the efficacy still cannot be guaranteed. So let's move on to the second objective, and I'd like to discuss the using the Remdesivir as an agent to treat our first patient. So our case is the situation is early February, we received about 230 evacuees from Wuhan city, and two of the patients, actually several patients, were admitted with PCR confirmed COVID-19 by CDC. And one of the patients was not stable. So this is the patient we eventually treated. So the patient, the clinical presentation, the patient has experiencing fever more than 101. Even she was on around the clock anti-fever medications, and but she has a worsening dry cough and shortness of breath. She was not intubated, was not on respirator, and she was very close to 94%, which is the cutoff to qualify for the Remdesivir trial, and by the time she was about to go under the 94%, that really actually triggered the decision that we need to treat her, because at the same time she had a worsening the blood pressure, and her lowest pressure was in the 50s, even though she was on continuous hydration with the ILR. So low blood pressure is a bad sign that the patient is about to start multi-vital organ failures. And at that time, it would be too late to treat. So that's why the decision was made to treat. And but what to treat? That was the really at the time we were closely monitoring the situation in China, and at that time the only available therapeutics was the two clinical trials opened. Actually, we probably started the therapy at the same time. There were two Remdesivir trials in China, in Wuhan. And one was for severe disease, the other one was for moderate disease. And we decided to use open-label Remdesivir. So, this will be our routine that we follow a internal process and working with the sponsor first to make sure that they are willing to donate the drug to our medical center. And next, we need to discuss with the FDA to have a quick approval of the therapy. So the regimen this regimen at that time was consistent with the two trials in China, and also consistent with the CDC's recommendation, which was to use 200 milligram loading dose on day 1, and followed by 100 milligram per day on days 2 to 10 to complete a 10-day regimen. So this is our process to whenever we have a expanded access. Before we talk to the FDA, there is a form 3622, 26. This has to be, it's the communication with the FDA that what your situation is. And FDA do have a 24 hours on call. So the locally, our infectious disease physician will call the FDA, explain the situation, clinical progress, and the reason to use drug, what we're going to use, and what the recommended proposed treatment plan. And at the same time, we would present a investigative brochure provided by the Gilead, which include all the preclinical data and animal data to support this the selection of this drug to treat our patient. And so we got approval almost immediately online over the phone, and locally we have the institution review board to approve, which is the IRB approval. This is the scientific, the ethic committee for human research protection. So, and as a research pharmacist, and the next thing we would do is to understand what this drug is. So Remdesivir, and I've shown you this is the chemical structure. Remdesivir is a nucleotide prodrug that is intracellularly metabolized into an analog of the adenosine triphosphate. It will inhibit the viral. It inhibits the RNA-dependent RNA polymerase and has a broad spectrum against different members of the filoviruses, including Ebola virus and Marburg virus, different coronaviruses, including SARS and MERS. And let me go back once. So let me go back once. So the binding site is I just show you, this is not the schematic replicase complex for COVID-19, because no one knows how it does. It's actually a SARS CoV-1. The binding site of Remdesivir is NSP12, which is a RNA dependent RNA polymerase. That's how it works. Mechanism of actions. So it binds to and inhibit the viral RNA polymerase, which will lead to a premature chain termination. Why are we using it? It's only because at that time when we started, there was no human experience using Remdesivir for SARS-CoV-2, but there were in vitro activities against the COVID-2, in vitro and in vivo activities against other related the beta type of coronaviruses. That's why it was really an extrapolation. So indication is a COVID-19, and this drug is given intravenously over 30 to 60 minutes if not tolerated. Our patient actually was able to tolerate all the doses, so all the infusions were given over 30 minutes. Formulation, it's provided to us as a sterile powder for injection, and adverse reactions, we only expected a mild elevation of a transaminase, and which was the case. So monitoring parameters, and it does have some potential toxicities in kidney and the liver. So kidney function and hepatic function should be monitored. So after 3 doses, it was a very successful treatment that our patient, the blood pressure was quickly stabilized and with no need for around-the-clock hydration. And after 3 doses, she had a multiple serum RT-PCR as a negative, and her fever quickly resolved. The only adverse events expected is the mild elevation of the transaminase. In her case, it was only 2 times, which is not clinically significant, and which also resolved in 2 days. So the patient was discharged after she completed only 9 out of 10 doses, because really she wouldn't need the last dose. And locally, at that time, the discharge standard was to have 3 consecutive negative RT-PCR results. They have to be done spaced more than 24 hours. So what we learned from this patient, it's looking at the virology of the virus, which quickly replicate in the early stage of the disease. I feel that if you have to use an antiviral drug, do it early and hit the virus hard when they are quickly replicating. So, our patient recovered pretty fast was because she was relatively young, in the early 50s, and she does not have an underlying disease. And looking at the safety profile, the Remdesivir is well tolerated with almost no side effect. So, well, at the same time, even though we successfully cured 1 patient, we have to keep a close eye on other therapies, and I'm sure you have interest in the numerous report of the chloroquine and the hydroxychloroquine. So there are some early data reported in other coronaviruses using the 2. And even though the mechanism of action I highlighted here as unknown, because no one knows. Traditionally, they were approved. They were indicated for malaria. They were used as a chemoprophylaxis agent, and hydroxychloroquine is indicated for rheumatoid arthritis and SLE. And how they work for COVID-19 is really unknown. I just copied this, the mechanism of action from clinical pharmacology online, and looking at the proposed mechanism of actions, it's really, I have to say, the summary is unknown, because this covers almost everything, potential therapeutic mechanisms, inhibit virus enzyme or interfere with viral protein glycosylation, interfere with viral assembly, and interfere with the virus release, or potentially block ACE inhibitors, acidification at the surface of cell membrane inhibitions, and immunomodulation of cytokine release. So I wouldn't say that this is the mechanism, and it's still unknown. And it means that we have a long way to go. Even they work, we need to understand exactly how they work. There's a lot to learn. And rationale for these 2 agents for the COVID-19 is because of the in vitro activities against the original SARS-1 and COVID-19, and in vitro data shows that hydroxychloroquine has a higher potency than chloroquine against COVID-19. Both drugs are given orally, and the formulation, another reason to use them is because they are readily available, and as a 250 and 1500 milligram tablets. Hydroxychloroquine is manufactured as a 200 milligram tablets. What are the concerns? The concerns is there is no robust data to show that both will work, but there's lots of adverse reactions we learned from other indications. For example, the cardiotoxicities and including the QT prolongation in especially in patients with hepatic and renal insufficiencies and immunosuppressed patients. So these drugs, and many of you saw the French trial using hydroxychloroquine in combination with azithromycin. The rationale is in their paper. Their rationale is that the Chinese trial use it, and so that's why they design a open-label, very small sample, non-randomized trial, meaning that you assign patients to the therapy, and then the control would be the ones who refuse the therapy, and altogether 36 patients were enrolled. The disease. They target hospitalized severe COVID-19 disease with oxygen saturation less than 94%. This is a single-arm intervention that hydroxychloroquine 600 milligram daily has been used, and azithromycin was added depending on their clinical presentation. So pay attention to their primary endpoint, which is the respiratory viral load after 6 days. And the reason it caught so much attention is because the patient who are randomized, who received azithromycin and hydroxychloroquine, they were all negative in their sample after 6 days. So their conclusion is that the treatment will lead to viral load reduction and disappearance after 6 days. And this effect is reinforced by azithromycin. So, the primary endpoint, interestingly, there is no clinical evaluation. It's just a testing, PCR testing over the viral load. Would they be better? And remains to be tested. So I listed the reference here, and you read the paper and make your own judgment. So, what's the take-home message? From this small trial without robust data, and right now, if you go to CDC, their position on the combination is that there's insufficient data to form a guidance on the use, the dosing, the duration. Should you use it for prophylaxis or for treatment? There's insufficient data. So really, the experience is anecdotal dosing regimen, dosing experience. So if you have to use it, the reported dosing regimens include 400 milligram BID on day 1, followed by 5 days of therapy, or 400 milligram twice a day on day 1, and 200 milligram twice a day for 4 days. That's also 5 days of regimen. Or 600 milligram twice daily on day 1, then 400 daily on days 2 to 5. So remember, pay attention to these regimens. These are anecdotal dosing regimens, not backed up by the CDCs. So this is a failed trial, Calitra. And the reason to use HIV protease inhibitor was because they were used, the combination with interferon, they were used in the MERS trials. And the trial design was this is a pretty robust clinical trial, up to almost 200 patients enrolled. And it was a controlled trial, and the patient were randomized 1-to-1. Half of the patient will get a placebo, half of will get a Calitra. And the disease, so they were targeting severe hospitalized COVID-19 patients. The regimen they were using was the 400 milligram opinavir and 100 milligram ritonavir, twice daily for 14 days. Primary endpoint, time to clinical improvement. Remember the other trial, it was just RT-PCR result. This trial, the endpoint is time to clinical improvement. So conclusion, no benefit unfortunately, in the primary endpoint, there is no difference between the two groups. And the second, before the trial, it was proposed that the Kaletra may function as an antiviral agent, but unfortunately, viral shedding continued. There is no antiviral effect. So this was quickly published in the New England Journal of Medicine. So that's a important trial. Even it's a negative, but it is very important. And in a sense that we need to understand, when you are receiving large bodies of, information from the media, from the publications, how you make an informative decision, and you have to learn how to read the data. Anti-inflammatory drugs is the last category as an interventional treatment category. So remember, ARDS is the main cause of death. So several agents were being tested, and corticosteroid, which was used in SARS-1. Unfortunately, there is no robust studies, and it can be tested, no conclusions or guidance. Because IL-6 receptor is highly, expression is increased, which is to mediate immune response. So several drugs, including tocilizumab, and then if you work in the oncology world, CAR T cell and has been approved for acute leukemia, and one of the major side effects of CAR T cell is the cytokine release syndrome, and many of you probably know that tocilizumab has been used as a rescue. One patient experienced cytokine release or cytokine storm. So that's why locally we have been thinking about if a patient is already at a later stage, can we use a CAR T cell regimen? Can that be considered because the clinical presentation is very similar? Last objective is really the lessons we learned, and it's every day we receive new information, and I just want to share some suggestions to you as a frontline pharmacist who are dealing with the COVID-19, or you also care other patients when we are still going through this pandemic. So professionally and personally, I'd like to, I'm always pursuing new therapeutics, but as a research pharmacist and as a frontline pharmacist, you should always try to deliver the right drug to the right patient population at the right time with the right dose. So let me repeat this: to deliver the right drug to the right patient population at the right time with the right dose. So the reason I want to repeat this twice is because you may see hundreds of clinical trials using all kinds of agents, and then people claim that they are helpful, or you may see case report, and like in our case. So I want to pay attention to my presentation. My presentation is a case report. This agent worked for my patient. It's only a case report. It may work for others, it may not work for others. So it is important to design controlled clinical trials so that we know exactly whether this agent will work. And there will be many drugs developed, and so that's why how you at the bedside make your decision to make the choice, and you have to be able to extract information from the literatures, and don't only count on case report. And the right patient population, and remember lots of the senior citizens die from the disease. The fatality rate is very high. So that's why you should pay attention to relatively senior citizens. And interestingly, the children have a less, it's less severe for the children, and then the fatality rate is very low. But remember, you have to understand virology of the virus, that people may not have symptoms, but they may shed viruses, so they may spread the virus. Well, they themselves have no problem. So that's why epidemiology interventions is critical. With the right dose, I just point out the dosing regimens for different drugs, and the reason is that for certain drugs, for example, the hydroxychloroquine, the dose used for other disease was tested, but in clinical trials, there could be doses that was never tested at that high. So that's why it is also important when you use a new agent for a different indication, and you need a clinical trial to monitor the side effect. So how you can, I think is critical. There will be large quantity of scientific literatures and report. So I hope that you can make an informative decision when the data is presented to you. So the last few suggestions, and don't forget that we are going through a pandemic, but many other patients are still sick, and then you have to take care of them. So I know I have many pharmacists in the audience, and when you practice, you should continue to care for those patients, especially for patients who are immune compromised, because they are at a much higher risk of being infected. And we already experienced massive cancellation of oncology patients. They're worried that if they come for chemotherapy for their cancer, they may be infected. And so that's why I always ask if your patient is immune compromised, either they are receiving chemotherapy or immune suppressive therapies, or they have HIV, and pay attention to these patients. And secondly, when we have a lockdown or shelter in place announced, many patients are in the situation that they run out of their drugs, so they can't go outside, and they are not to go outside. Would they have enough supplies for their own disease? For example, the diabetes patient, would they have enough insulin or metformin? And do they have hypertension drugs? So if they don't, make sure that they stock enough for at least a month. So these are the things for general pharmacy practice. Pay attention to the supply and then the need of the regular patients. And number three, as a FDA just notified that because of the shortage of a hand sanitizer, and now we are allowed as a pharmacy to formulate or compound alcohol-based or other anti-infection sanitizers, we can compound. So you should have a formula and be ready if you do have a shortage. And as a pharmacy director and hospital administrator, you have to make sure that when you do have a labor reduction, because it's you may have frontline people infected and then they have to stay at home. Do you have the technology to support telepharmacy and telemedicine? And sometimes the patient cannot come to the hospital. Can you do remote pharmacy, remote patient care? And the last one is we scrambled several University of California, the Investigational Drug Service. We're scrambling to create a mail-out service. We send a research drug to the patient and who are not allowed to travel. So, that's pretty much the end of my presentation. And lastly, I'd like to give a shout out to the service, the research pharmacy service. That this is the first time in my career that science is behind disease. So, but at least at major academic centers, we have an infrastructure. We have a dedicated research pharmacy team that when we're needed, we're able to quickly process the research drug. And if you do not have such a service in your department, maybe it's time to consider to establish a service. Because this is not the first time, and it won't be the last time that there's no standard of care therapies. And thank you for your attention, and thank you for this opportunity to share my experience with you. I'm sorry I'm a little over the time allowed, but I'm happy to take some questions.
Thank you very much, Dr. Sang, for this very comprehensive and informative presentation. In fact, we're actually happy that you went over time because we have a very long list of questions. I'm gonna try to pick the most important ones of them first because we appreciate that, and we also respect your time. We're sure that you have other things to do. But before I start with the questions, so there is this comment by Dr. Abdul Khaliq al-Salman, and then after this comment, I'm going to go into the questions. For chloroquine, he's mentioning one of the potential mechanisms of action that were suggested in one of the published studies. It says chloroquine is a weak base that blocks the function of lysosomes. And that it diffuses into lysosomes and becomes protonated, raising the pH and the ionic strength of lysosomes. When the pH rises, the lysosome enzymes fail to function. Viruses that require acidic pH to diffuse into the cell membranes can no longer do so in the presence of chloroquine, and so the cells are protected from the infection. I assume this might be similar to, or like a kind of a different mechanism of action that was presented. But I think it's one of the assumptions. I don't know if you have a comment on this.
I have no comment on that. That's the traditional mechanism of actions.
Okay, thank you. Okay, so moving into some of the questions were actually posted while you are still presenting, so I believe that their answers have already been presented by you, like, for example, the role of azithromycin and so forth. But one of the important questions that came up, actually more than once, what about favipiravir? Does it have a similar mechanism of action as Remdesivir?
I've seen some report, and there is no robust data. Preliminary report.
So you don't support its use during the current stage?
So it could be tested. It probably will be tested, but there's no robust data reported.
Okay. Thank you for that. There's this question about a rapid test for COVID-19. We heard that the FDA has recently approved one, so if you can comment on that.
So we have the original test is the RT-PCR based, and there's a serum test, serologic testing, and targeting the spike proteins. So these technologies, and I wouldn't comment on the FDA assay, but technology-wise, the RT-PCR and then the ELISA, which is to test IgM, IgM actually you might see an increase of IgM in the early stage, even before the nasal swab is positive. So ELISA, using ELISA technology to detect the IgM may be the way to go, and it doesn't take long to get the results. So locally, University of California, we were allowed to work, the 5 campuses were allowed to work together to develop our own in-house rapid testing, and hopefully this week we would have something with a turnaround time, shorter than 12 hours, maybe as fast as 6 hours. I think this is a critical, especially for frontline personnel, and if people with a suspected syndrome, and would we send them home and quarantine them 14 days, or wait in line for the traditional testing, or we have our own testing, which we would know in a few hours. So I think the testing is right now has been very slow. And but I think locally, academic centers are developing their own assays, and technology-wise, is not hard.
Yeah,
These are old technologies.
I think we heard like Cepheid is now developing one that returns the result in about like 45 minutes. I think that came into the news, I think, last night.
Can you repeat the question, please?
No, I mentioned that Cepheid has been working on a test that returns the result in about 45 minutes. So I'm not sure if you.
Oh, really? Okay.
Okay, so another question also regarding the diagnosis, and also this came actually more than once. Are there any laboratory tests that can also indicate the presence of COVID-19 in a symptomatic person where a COVID-19 PCR test is not available, like in the CBC or in like inflammatory markers?
Other markers?
Yes, any other markers, any other lab tests that can also aid in the diagnosis of COVID-19 where PCR test is not available?
I think the IgM testing using antibodies would be the way to go for surveillance, large population screening. So I'm not aware of approved studies, but I think many companies are trying to develop this rapid testing using antibodies to target the surface protein, the spike proteins. Okay. But I'm not an expert in those diagnoses, so it's just the information I received.
Sure. So another question is about the use of oseltamivir, Tamiflu. What do you think about it?
I have not seen any report. Maybe I missed those reports.
Okay.
But go ahead.
Yeah.
The previous question, I think there has been a theory that the sampling from the nasal swab and then the serum PCR. So our patient actually was discharged with a negative result, the RT-PCR in the serum. But the RT-PCR was positive in the sputum. So looking at the viral shedding, it may last for about 2 weeks after the symptom resolve, and for severe patient, it can be even longer. So I think after discharge, even though you have a serum RT-PCR negative results, it's still necessary to isolate themselves after discharge, because it's possible that they're still shedding viruses. But this is just a precaution. RT-PCR is based on the RNA. It doesn't mean that there are a quick replication of viruses. It's just that they can be detected. There's still a nucleotide RNA in the sputum. Even the symptom resolve.
Okay, so meaning that even after the patient has fully recovered, they can still be shedding the virus. So in that case, how long would you ask the person who has completely recovered to quarantine themselves?
I actually look at this was my question, and looking at the report, I think for mild, if they presented as a mild and they recovered, it's about 2 weeks. And for severe, it's more than 2 weeks. So I do not have actually 7 to 12 days for mild and moderate. For severe, it's more than 2 weeks.
And is it,
so again, this is based on preliminary report.
Sure, and is it like highly recommended that we do a follow-up test for every patient who has tested positive initially, to confirm that they're no longer shedding the virus and that they can engage in the community again?
I think that's a good idea, and also it cannot be RT-PCR only, and because again the antibody, the IgM or those needs to be. It's better to have a confirmation with the two different technologies if they're available.
Okay, a very good answer. Thank you very much. This is a question that actually came several times. Are there any reported asymptomatic carriers? And if so, how can we know that this person is a carrier and have to isolate her or himself?
I think that's why it's critical to have a surveillance program or diagnostic tool, and especially to do a large population screening. And because the RT-PCR is sensitive enough to pick up the viral RNA, and even without the symptom. So what the delay here in the States was because we only tested the people with symptoms. As I mentioned in the beginning of the talk, the virus shedding already started for 2 days before the symptom. And up to 70% of the people who shed viruses will become symptomatic. So it is critical to do early detections, and if available, I think a population screening using a rapid detection is necessary, and besides the epidemiology controls, self-isolation and first, and if possible, to offer the large population screening. But again, we really need a good technique.
So what do you think about the use of IV immunoglobulins, IVIG? There are some, I think...
I've seen report, but again, no robust data, so we can't draw conclusions or it might work.
And then this is also a recurrent question about the use of angiotensin converting enzyme inhibitors, ACE inhibitors, or angiotensin receptor blockers.
Interesting.
Yes. Is there like a
I know
risk
someone will
increase
ask
the risk
this, yes.
for the infection?
So it's a very good question. So here's the theory. The theory is that the ACE2 inhibitor will be upregulated when you have a inhibitor. The receptor will be increased in the presence of an inhibitor. And when patients take these medications to control their blood pressure, they may have a higher baseline of ACE2 receptor. So in theory, these patients will have a higher risk of being infected because they have a more target. So to respond, you might want to decrease the use of ACE inhibitor. This theory was proposed and circulated, but about a week ago, the three major medical community directors all made a joint announcement that do not stop ACE inhibitor, and because there's no evidence to show that those patients are more vulnerable to infection. So right now the data is conflicting. So let me really, what is the connection between this, the increase of a receptor and then the increased risk? Nobody knows. Need some additional research. But at the bedside, if you can switch your patient to another anti-hypertensive drug and then get the pressure under control, well, we're still studying the link. It may not be a bad idea, but again, it's not a guideline that you need to stop it. And but I think it's a good idea to switch to something else. What if it has a connection? So if you can get the blood pressure under control with a different drug, for example, amlodipine, and why not give it a try?
Okay, thank you very much. Yes.
And okay.
Now, if you have something to add, feel free to add, Dr. Sun. Okay.
Oh, no.
So what about the report about the use of ibuprofen and that it increases the risk of complications?
I've seen I've seen report, but I can't draw a conclusion of the anti-fever drug, the connections of the anti-fever drug to the fatality or the. I've seen report, no conclusions.
Fair enough. Are there any complications after healing? We also got this question several times. After a patient has healed.
So if we're talking about pulmonary fibrosis,
in the population, I mean, are there any complications? So yeah, perhaps pulmonary fibrosis, yeah.
So pulmonary fibrosis could be a permanent pathological changes, and actually when our immune system is trying to control the situation, that's one of the mechanisms to scar down. And unfortunately, the pulmonary alveolar will be insulated with a very thick layers. So that's how why oxygen cannot penetrate anymore. So those are relatively irreversible pathological changes. So there could be a loss of lung function. But this, again, it's a little early to tell because we're still in a pandemic phase.
So this is a question of two parts based on the question has been, several questions has been reported. So does a recovered patient develop immunity against further infections if exposed again? And if that's true, is it possible that we use the antibodies that this person developed or produced to use them in other infected patients?
That was the passive immunity that I mentioned here. The immunoglobulin here. Yes. So the answer is possible. The last one here, immunoglobulin and monoclonal antibodies against from other patients. This will be the textbook passive immunity. But again, it's going to be challenging because you won't be able to purify sufficient amount from the recovered patients. So bioengineering probably is a large-scale production of bioengineered globulin is probably the way to go.
And then is it true that there are reports about a second strain of the coronavirus? And so a person who has recovered may get infected again by the second strain?
So I've seen sporadic report that the recovered patient that got infected again. Even though there's no, we have to see more data, and you have to do that diagnosis to see what strains they were infected. And I said this virus can mutate pretty fast at the genome and also on the spike protein. So so if in theory, patient shouldn't be infected by the same strain, but if the strain mutates so much, and then the patient becomes immune compromised, it's possible, but I think the chance is very low. And I actually look at the bacteria because during that time the body is going through pathological changes, and there hasn't been concomitant infection of a bacteria. So will that be possible? Possible, but maybe rare. And again, it's depending on the From the SARS CoV-1, there were remember about 25 of the RNA sequence will be different when the human go through multiple rounds of infections. So, but that is something remain to be determined.
Do you have any experience with pregnant women? Are there any precautions with regards to which drugs to be used or any additional precautions?
What is the experience?
With regards to the treatment, with regards to the drugs, are they the suggested drugs like the antimalarials and such? Do you think they are safe in pregnancy, or if you have any experience with that?
So in our hospital right now, our only existing if we have to treat, the only treatment is actually Remdesivir. So we are enrolled in a phase 3 trial with NIH, and which is a double-blinded phase 3 trial, and targeting the hospitalized patients. And we have no plan to use hydroxychloroquine and azithromycin. No plan for chloroquine.
Okay, thank you. This is also a recurrent question. Are there any specific blood types that are more vulnerable to the infection than others?
Not on top of my head. I've seen report. I think don't quote on me. Well, I just wouldn't answer that question because I don't see those info. I know that there has been report. I do not see statistical analysis of those reports. I realize that people are thinking certain blood types are more resistant to exposure, and meaning that others may be more vulnerable. But again, when you review the data, you need to see the statistical analysis there.
Okay, I don't think this was. I don't know if you.
Otherwise, it's a rumor.
Yes. So I don't know if this was mentioned in your presentation. We may have missed it, but someone asked about the dose of chloroquine.
Chloroquine, it's not. Let me see if. I provided a link, which is the CDC's. The reference here is the therapeutic options. I don't remember there was a chloroquine dosage recommendation. So, but you're welcome to go to this reference and then look at the if there's a references.
Yeah, I just checked that a couple of hours ago because I was also working on our hospital guidelines. But yeah, there's no mentioning of the chloroquine doses as was just mentioned. Only the hydroxychloroquine.
Right.
But I believe.
And
yeah, I believe other references have it. So.
Right.
Okay, so. One was, okay, so I think I'm going to just end up with perhaps one more question. Do you know the fever temperature? I mean, in Celsius, because that's the unit that we use here.
Oh, I see. 104. So my formula is minus 32 divided by 1.8. Let me grab my calculator. So 104.
104.
Minus 32.
That's around 40. Okay.
38.
Okay.
38 degrees Celsius, centigrade.
Okay. We have like a lot of other questions. Someone is asking if there is a difference in the efficacy of treatments in males versus females.
There is no. You mean the Remdesivir?
In general, I mean, no, the question was not specific to a specific drug.
I have not seen, those are the things typically are reported in the large scale, the control trials, that the patient will be stratified according to sex and age. Right now, the two trials, the two Chinese trials will mature at the end of April. So I'm sure you will see data, and the patient will be stratified based on their sex. And the phase 3 trial that we are just open, and that will enroll, actually the Chinese trial will enroll 400 and 300 respectively. And the NIH trial that we are qualified will enroll about 440 patients. So age and sex and underlying disease will be stratified. At that time, we would know whether Remdesivir will make any difference, male versus female.
Well, thank you. We definitely look forward to seeing these results. So I'll end with this request. Some people are requesting if you can kindly provide a copy of your slides, like as a handout.
I think so.
So maybe you can contact with the organizers. We would really appreciate that. I think we have Mrs. Maureen Quran with us here, and I think she wanted to just provide a conclusion before we finish. So the mic. Mrs. Quran, I don't think we can hear you. If you can just make sure that the mic button is green on the top left.
Can you hear me now?
Yes, we can hear you now. Please.
Okay, great. Well, I just wanted to, first of all, thank all of the audience for participating today, to Dr. Mouric and the Saudi Pharmaceutical Society for providing this great opportunity, certainly to Dr. Sun for his great knowledge and wisdom in working with COVID, for providing this presentation, and to the rest of my team, Dr. Soliman and Dr. Delaney, for their support in getting this organized. We really look forward to continuing to work together to tackle this pandemic, and know that at UC San Diego we're here on the front line and working together as a whole global community to tackle this problem. So thank you, and thank you, Dr. Abrar.
Of course. Well, thank you very much for joining us at the end and for this nice conclusion. I believe we have reached over 2,400 participants in this presentation, which was quite impressive, definitely from more parts of the world than just from Saudi. So at the end, we really like to sincerely thank you, Dr. Sun, for your contribution and for this very comprehensive, detailed lecture. I think a lot of us have benefit from it. We would also, again, like to thank the Saudi Pharmaceutical Society for organizing this with the University of California, San Diego, as well as with the Virtual Medical Academy. So thank you very much, and we hope to get the handouts from you soon so we can distribute them to the participants.
Thank you very much.
Thank you. Have a good day. Bye.
You too.
الأكاديمية الطبية الافتراضية، اختيار جديد. medicalacademy.org